Good morning, everybody. Today I will discuss the opioid analgesics and their antagonists. You know, opioid analgesics are used every day in anesthesia practice. So these are used for pain management and an adjunct to anesthesia and critical care. Opioids are the cornerstone medication for the treatment of moderate to severe pain and are commonly used in the perioperative care of patients to provide analgesia. This course lecture provides a brief overview of the mechanism of action and various routes of administration. For dosing guidelines, you can see the appendix on drug information. Mechanism of action. Opioids bind to the opioid receptors, which couple to G proteins and inhibit the adenine cyclase, leads to inhibition of voltage-gated calcium channels and opening of potassium channels, results in increased intracellular potassium, which leads to decreased neurotransmission. Receptor subtypes. The physiologic function of opioid receptor is to bind the endogenous opioids and provide the endogenous analgesia in response to pain. Mu receptors are in the brain, spinal cord, and periphery, and are the primary receptors responsible for the analgesic and adverse effects of opioids, especially morphine. Mu1 subtype, this is for analgesia. Mu2 subtype, this is for hypoventilation, bradycardia, and physical dependence. Kappa receptors inhibit the neurotransmission via the calcium channels, responsible for dysphoria and diuresis. Delta receptors modulate the mu receptor activity. Endogenous opioids include enkephalins, endorphins, and dynorphins. Structure-activity relationship. The term opioid is used to describe compounds derived from the poppy. The prototype is morphine. Opioid medications, completely synthetic or semi-synthetic modifications of morphine. C. The representative opioid medications: hydromorphine, meperidine, that is pethidine, fentanyl, alphenadine, sufentanil, and remifentanil. Administration of opioids. There are multiple routes of administration, including oral, parenteral, intramuscular, neuraxial, transdermal, and transmucosal. Parenteral administration is distribution. onset and duration of action depend on the lipid solubility and ionization of the drug. Drugs diffuse across the blood-brain barrier and redistribute to inactive tissue sites such as skeletal muscle and fat. High dose of lipid-soluble drugs, for example, fentanyl, lead to saturation of inactive sites and buildup of the drug in the plasma, resulting in a longer duration of action. Metabolism. Most opioids are metabolized in the liver and excreted by the kidneys. An exception is remifentanil, which is rapidly metabolized by plasma esterase. Main opioids having long-acting pharmacologically active metabolites, normeperidine, that is norpethidine, is the active metabolite of meperidine and has renal elimination. Accumulation can cause the seizures and should be used with caution in patients with renal failure. Morphine 6-glucuronide is an active metabolite of morphine and can accumulate in neonates and those with renal failure. Neuraxial administration. Neuraxial opioids act on the mu receptors in the substantia gelatinosa of the spinal cord. Epidural administration requires diffusion across the dura to bind receptors in the spinal cord. Spinal administration requires lower doses because diffusion is not necessary. The typical spinal dose to produce the desired effect is 5 to 10 times less than the epidural dose. The pharmacokinetics. Lipid-soluble opioids, that is fentanyl, have more IV absorption and shorter duration of action. Water-soluble opioids like morphine have a longer onset but longer duration also, presumably due to increased time needed to diffuse across the dura. The duration of action depends on diffusion of the drug out of the cerebrospinal fluid, that is CSF. CSF and into the blood and not on metabolism. Effect of neuraxial opioids. Analgesia. Effects of neuraxial opioids, the analgesia, pruritus, urinary retention, hyperventilation, may be delayed up to 12 hours, especially after neuraxial morphine administration. Hypothermia, nausea and vomiting. Transdermal or transmucosal administration. Both routes avoid the first pass metabolism. Fentanyl can be administered via either routes due to its high potency and solubility in both water and lipids. Thank you. This was this much for this class of today.